Good morning, good afternoon, good evening, wherever you are. It's a pleasure to have you all here for our ReSViNET webinar. Today, we will again emphasize our vision to connect global expertise and leadership in order to decrease the global burden of RSV infection, with the mission to support the performance of high-quality research to improve knowledge of RSV epidemiology and to support the development of preventive and therapeutic interventions and global implementation strategies, with the goal to advocate for and create awareness of RSV, combine knowledge and capacity required to enhance the development of novel RSV therapeutics. And by the way, I should have mentioned, my name is Lewis Bond, and I'm your moderator today and the ReSViNET chairman. So, today's webinar is about designing RSV effectiveness studies in low and middle income countries, and we're going to learn from lessons from rotavirus and pneumococcal infection. I want you to notice that we have a Q&A button. Please use it to ask your questions while Rita, whom I will introduce in a second, will talk, so that we have a nice Q&A session by the end of the presentations. So the first speaker is Rita Rayburn. She is technical officer, an epidemiologist, integrated communicable diseases expert at WHO in Laos. And I have come to know Rita really very well because she recently graduated as a PhD student here at Utrecht University. She will tell us the lessons she learned from other diseases on real-world evidence, and then I will give a short presentation on real-world evidence for RSV immunization strategies, as far as we know from high-income countries, because we don't have anything for low- and middle-income countries. And then after these two presentations, there will be ample time for Q&A. So without further delay, I will hand the microphone to Rita.
Thank you very much, Lewis, for the kind introduction, and good morning, good afternoon, and good evening to everyone. It's evening for me. I'm in Laos, 9 p.m. So as Lewis mentioned, I'm going to present to you about designing post-licensure studies for RSV immunization evaluations in LMICs. And I'll talk about lessons learned from the pneumococcal and rotavirus studies that I conducted. So as we all know, you're very familiar with this, there's a gap in the burden of severe RSV compared to the introduction of the immunizations. And if we were to overlay the map of where the immunizations are being introduced, it's almost the inverse of the burden, with the exception of South America that is very impressively moving forward quickly with introduction and quality evidence. So in September 2024, the WHO SAGE recommended universal RSV prevention via maternal vaccines or MAB. So it's almost exactly 1 year ago. And very recently, Gavi issued a statement saying it welcomes the first ever pre-qualification of the maternal vaccine. And they also had conducted an investment case which showed that the maternal vaccine is cost effective at reducing DALYs and deaths compared to the other Gavi-funded vaccines. So that's very positive. They will open applications in 2027, and the funding would prioritize procurement, and the delivery costs would be domestically funded by the governments. They expect around 8 countries to move forward with Gavi-funded programs in 2028. But the modeling shows that it might take a decade or more for most Gavi countries to introduce the vaccine. So this is relatively slow considering we know the global burden. So in order to accelerate vaccine uptake, we should generate locally relevant evidence. So yeah, as I said, on the global level, we have an understanding of where the burden lies, but we need data to show that, and we also have data to show that the vaccines are efficacious and effective But for me, I really feel like vaccine impact data is really the key, because this will demonstrate to policymakers the reduction in disease in their population. I observed the WHO SAGE last year, and it was really interesting to see that a lot of countries, LMICs, were prioritizing strengthening the already existing vaccination programs over introducing new vaccines. And this is understandable because the countries will need to take over the funding, and some of them are close to graduation, and many middle-income countries don't receive any support. We really need strong impact data for these vaccines. So together with Lewis and other co-authors, we wrote a paper about considerations for study designs for RSV immunization evaluations. And for impact studies, it's really the pre versus post introduction study to assess population level impact as a reduction in RSV related outcomes in the post-vaccine period. So this table here comes from the Chile study, which was presented also in this forum. It was a very nice presentation with excellent data. And they showed strong impact for MAB, that around 78% reduction after introduction compared to the 3 previous years average. And then also converted to an estimated cases averted. So it was very impressive that 4,600 cases were averted. So this kind of data is really what I think will make a difference for policymakers, the number of cases prevented by introducing the vaccine. And Chile is a upper middle income country, so if we can get more data from lower income countries, this will really help to shift the needle and get it introduced faster. So for impact studies, you require a stable surveillance system, and we would suggest that you need to capture at least 2 years pre-RSV immunization data to account for annual variability. You can have multiple outcomes, but of course you need to be able to measure those accurately and stably over time. So then thinking about methods to evaluate effectiveness. So case control studies, and particularly the test negative design, are very practical and not so resource intensive. They require a sensitive diagnostic test, which is available for RSV. So there's a lot of, this is really the test negative design is what we're seeing most of the studies that are coming out now. And this takes away a lot of the problems of control bias. And then, of course, there's cohort studies, which are very high value because you can have multiple outcomes, but they're resource intense and you require linked registers. So that is this is not common, even in high-income countries. There are some sites with existing demographic surveillance systems, and these should be really prioritized to conduct high-quality effectiveness studies. I can think a couple off my head, like the Gambia and Khalifi. And so here, this table shows the data from Argentina for their test negative case control design, and it just showed a high vaccine effectiveness across multiple outcomes. So this is really encouraging. So surveillance is really the foundation of any of the study it designs, and the key considerations are quality diagnostics. As I said, these are available for RSV, but you need to make sure that people conducting the tests have the capacity, that that it's stored well and data is recorded well. You need multi-year data stability, particularly for the impact studies, because you're looking at the change over time at the point your vaccine is introduced. You want a representativeness of the catchment population, which isn't always easy because it's much easier to conduct studies in a large tertiary hospital rather than in primary healthcare, where many of the higher risk population may be. And the surveillance champion, I really want to highlight, it's a very, it's a very practical point, but it makes such a big difference to quality data. if you have a well-trained person, such as a study nurse who is leading the surveillance, enrolling, conducting the tests, recording the data, it really, you get very high quality data. And if not, and we've done it where it was, we wanted to hand over to the routine clinical setting for, sustainability and building MOH capacity, but what happens is the clinicians are very busy and it's a challenge for them. And this picture kind of highlights the type of records that you would see in an LMIC. It's mainly paper-based and have a lot of forms, often vertical reporting programs. So there's already quite a significant burden on the staff to record data. So therefore, I really recommend, a surveillance champion. Community-based surveillance is really important to identify the cases that never reach the healthcare setting, and this should be prioritized in high burden settings. So looking at the lessons that I learned from our pneumococcal conjugate vaccine impact evaluations in Fiji. So we used routine data to evaluate the change in pneumococcal disease following vaccine introduction. We retrospectively extracted the clinical and lab records and reclassified the cases as severe hypoxic or radiological pneumonia or invasive pneumococcal disease. And then we complemented this with annual pneumococcal carriage surveys in the community. And it was very, very challenging because pneumococcal is very difficult to measure. All of these outcomes have their own challenges. But we also lacked a stable surveillance system, and we were using routine data. And throughout our time there, we improved the diagnostics. So if you have a look at this graph, you see the purple bar in the under twos. You see a paradoxical increase just after the vaccine is introduced, and that was because we put a lot of effort into strengthening diagnostics. So we were able to adjust for this using our pneumococcal carriage data, but it was not ideal. There was also a challenge of a lot of missing data, lost records, or oxygen had never been measured, things like this, and the missing data was biased by time, so more records missing previously. And we used multiple imputation to account for this missing data, but it was not ideal. So in contrast, our rotavirus vaccine impact evaluation in Fiji were much easier to conduct and much easier to interpret with much more impressive results. And we used the same study design using routine data to assess the change after the vaccine introduction. But there was a long-term surveillance and we had clear outcome measures with reliable diagnostics. And you can see here in this graph, the rotavirus diarrhea admissions in the orange reduced significantly when the vaccine was introduced compared to the all-cause diarrhea admissions, where there was relatively no change. So this was very strong evidence for the policymakers. And it translated into a reduction in admissions in the ward, so freeing up the healthcare system. We had limitations again of missing data, and this was mostly around stool samples not being collected. And it was more pronounced in the post-vaccine period, because in the pre-vaccine period, we had a study nurse, and in the post-vaccine period, this surveillance was being taken over by the Ministry of Health, and exactly the challenges I described earlier of the teams being very busy. So for this side, I wanted to highlight the importance of understanding changes in access to healthcare. And these could be things like admission criteria, case definition, or diagnostics, or even something like improvements to road and transport systems so that people get better access to hospitals. We did a study where we looked at the change in the WHO case definition for severe pneumonia, and we found that it affects the epidemiology and therefore the interpretation of any impact evaluations. So in 2013, WHO updated the definition to remove lower chest wall in drawing, which was beneficial for clinical reasons. But So when we analyzed this, we found that 6 out of 7 sites, if you look at the percentage of all-cause pneumonia hospitalizations due to severe pneumonia, it significantly declined when you just change the case definition. So we had the same children, same data, but we classified them using the 2 different case definitions. And I think, and these things are not obvious. When you come to start a surveillance somewhere, this is often not documented. So it's worth spending some time speaking to the local staff and understanding what are the changes that have happened in the surveillance system over time. Outcome measures. Obviously, the RSV specific outcomes are really important and will generate the strong evidence, but it would be important to complement them with the broader outcome measures such as bed utilization, because I feel like this is going to be really important for policymakers in LMICs to see the value of the vaccine. So in conclusion, universal RSV prevention is feasible and endorsed by WHO and Gavi. And to accelerate the uptake, there is a need for locally relevant evidence. And personally, I think we should focus on impact because the effectiveness is already quite clear that it is effective. And the investments are needed in surveillance systems for RSV and vaccine preventable diseases in general. If we, as new vaccines come out, if we have good burden data, there will be quickly uptake and we will be able to evaluate them easily. And I think it's important to conduct some very high quality impact and effectiveness studies in settings with high infant mortality and including community-based surveillance. Thank you.
Thank you so much, Rita, for giving us your insight into a lifelong experience of real-world evidence data collection from the WHO perspective. It's good to see that there are so many people here on board during this webinar, Rita, not just our colleagues from WHO, but also our academic colleagues. I recognize many of them from all over the world. Our colleagues, the manufacturers of the vaccines of RSV that we're currently introducing worldwide. So it's really good to see all of you. So I think I'm going to ask Isabel to share a short PowerPoint that I prepared to show you the real-world evidence data that we have so far, because every week there is another paper coming out, and I thought to give a short overview. I used a couple of slides from Marta Nunez, so I want to acknowledge that up front. So what I'm going to show you is what we have so far generated over the past months in terms of maternal vaccination effectiveness, monoclonal antibody effectiveness, and viral resistance against monoclonal antibodies as piece of real-world evidence. To show you how these concepts of Rita translate into the real world, the first couple of slides you will recognize partially. So if we start with the maternal vaccine that is currently introduced worldwide, you can see that more than 1.4 million doses have been administered, many of them in the Americas, and but also in Europe. And we can learn lessons from them. So basically what you learned from Rita is that if we look into the population after introduction of the maternal vaccine, we're going to test infants for RSV. And some of them will test positive and some of them will test negative. And then again, some of those who test positive were vaccinated and some of them were not vaccinated, and some of the controls were vaccinated and not vaccinated. And by comparing these proportions, we can calculate effectiveness. So when we do that here, you can actually see among the positive cases, only 18%. So I hope you're at slide 5 now. I'm trying to move forward. Oh, wait, I think I'm okay. So this is the slide where you, thank you, Isabel, for making that. I hope you can this is slide 4. Rita, can you nod if this is slide 4 that you're actually seeing, or just say yes or no? You see slide 5.
Slide 5.
Hi,
Okay.
Louis. Isabel here. Can you take over control in the top bar of your screen? On the left side, you will see take over control.
Okay. I think I just did.
Yeah.
Perfect. So, so this is the slide that shows among the positive cases that 18% had a mother who was vaccinated, whereas among those who test negative, 50% was vaccinated. It shows that there's an imbalance here, and that can be calculated to effectiveness. So in this case, depending a little bit on the outcome, it's between 70 and 80% effectiveness. If we look at the United States, there are two network studies, VISION and NVSN. Along the same lines, you can compare, again, RSV positives and RSV negatives, and those who were and those who were not vaccinated. And then you can actually see, again, that among the positives, only 19% was vaccinated, whereas among the negatives, 37% was vaccinated. And here you get very similar numbers in the other network study, 18% versus 33%. So these can be calculated again around 70 to 80%, which you can see here, 70 to 80% for both networks. So this is encouraging and consistent. And if we take that to the United Kingdom, again, depending on the exact details, you will find here among the RSV positive cases, and then all infants included, 19% was vaccinated versus 41%. And then in those who were vaccinated at least 14 days after, so who were born at least 14 days after vaccination, again, we get over 70% effectiveness. So this is the first glimpse that it is important that pregnant women are vaccinated in time, and when they deliver within 14 days after vaccination, effectiveness drops substantially. At least it suggests in this study. If we look at Scotland, again, we get 80% effectiveness, which is really good, even a little bit higher than the others. But again, if the immunization is less than 14 days, vaccine effectiveness drops. So again, an advice that if you use maternal vaccination, it is wise to do that in time. So I think this summarizes, to the best of my knowledge, what is out there in terms of maternal vaccination. There's a little bit more information about infant immunization. This is the first pragmatic trial with nirsevimab. This is still considered part of real-world evidence, even though it is a trial. And you can see here effectiveness or efficacy, it was called here, is 75.4%, even though it's not a classic phase 3 registration trial. And this is a slide that many of you know, I'm pretty sure, one of the first data after routine immunization in the world in Spain, in Galicia, where you see that in the columns, in the bars, RSV is almost gone from the wards, except in the population that does not qualify for RSV immunization because these children were too old. So here you can really see that after introduction of nirsevimab, the disease is substantially gone by 80 to 90%. If you go to Chile, it's a national birth cohort comparison. So really taking it to another level, 145 immunized versus 9,000 non-immunized individuals. Half of them were immunized as part of a catch-up, and the other was seasonal. Again, the effectiveness, depending on the exact outcome, was around 70 to 80%, with a higher effectiveness in the most severe outcomes, which is what you would expect interesting, and I think this is still to be considered anecdotal because it's derived with a different methodology. But in Chile, during the introduction of nirsevimab, there were no deaths, whereas there were 13 in the previous season. So in this case, we compare to historic controls with substantial methodological limitations. But it at least suggests that nirsevimab in Chile has an impact on RSV mortality. Then we have the French registry, again with a test negative design that Rita explained so nicely, with an ambulatory RSV bronchiolitis as an outcome, so the more milder version of the disease. Again, effectiveness of 80%. It's almost getting boring that the numbers are very robust. And in a meta-analysis that was published quite recently, and I think this is a good summary of what's out there, the effectiveness should be considered about 80%. So now we know a little bit about effectiveness, but for the monoclonal antibody, there is the general concept of concern of the development of resistance. Even though it's not out there, I think everybody find it important that it's not induced by the pressure of the use of the antibody. And we know from a previous antibody that theoretically this may happen. So in this study, the diversity of the RSV F protein was analyzed. And what you can see here is the RSV A and the RSV B fusion protein is much less diverse than the SARS-CoV-2 spike protein or the influenza phylogenetic diversity derived from the phylogenetic trees of the H1, H3 proteins. So that means that the F protein is conserved. So that at least is reassuring. And then if you look at mutations in the nirsevimab binding site for RSV-A on top and RSV-B below, you can see that there are some mutations or differences in the genetic makeup of the nirsevimab binding site, and rarely, but it does occur, but it's very rare, it confers resistance, in particular in RSV-B. So if we move forward, and then I'm close to the end of my presentation, then you can actually see in a recent study from France that they did find a few breakthrough infections. Many of them were not resistant to nirsevimab, but actually in the RSV-B strain, again, the B strain, there were two mutated viruses that were resistant. Whether or not this was induced by pressure of the use of the antibody, or, and I think this is more likely, just a variation of the virus in the population, and then you will find once in a while a strain that is resistant. But these two RSV-B strains, they were basically fully resistant, and we need to ensure that they don't take over. So what I showed you is that even though the methodologies were very, very different in the post-marketing studies in Europe, North America, South America, the conclusions were quite consistent in terms of effectiveness of both the maternal and the nirsevimab data, and that so far for the antibody there is no evidence of the development of resistance, but we need to keep on following that. So I would like you to ask your questions through so this ends my part of the presentation, and now Rita's presentation as well as mine are open for Q&A, and please ask your questions in the Q&A box so that we can start the discussion. Thank you very much, and I will stop sharing. So while people are people, sorry, I need to check whether do some people maybe use the chat. No. So please use the Q&A button for your questions. So Rita, there's quite a bit of data coming out from middle and high income countries now that are suggesting consistency of effectiveness in different regions of the world and different socioeconomic backgrounds. What does that mean for the predicted or expected effectiveness of either the maternal or the monoclonal antibody in really poor income settings, such as the Gavi eligible countries?
Yeah, thanks for this. I think it's really promising and exciting that the results are so consistent.
Sorry,
Can you hear
I can't.
me? Sorry, I'm in a room. There's a bit of background noise where I am. How is that? Is that better? Can you hear me?
Yes,
I can hear
yes.
you.
Yes, we can hear Rita.
Okay, thank you. Yeah, I think it's very, very promising that the results are so consistent. Oh, sorry. There's an echo.
Yeah, go ahead.
Now. But I think we would probably, yeah, so the evidence so far that they are very consistent. I think it would be important to conduct this in LMICs with, high infant mortality, or also with other comorbidities and other underlying conditions, particularly for the maternal vaccine, because there's more steps on the kind of pathway for the child to receive the passive immunization. The mother has to active immunity, and then have to pass the antibodies on. So I think in the biological chain, it's more likely that there could be differences between in different settings based on whether the mother's underlying health condition or nutrition or other comorbidities. So I think we definitely would like to see some more effectiveness from the full spectrum of income settings and RSV burden. But I think, yeah, I'm hoping it will stay consistent. I would imagine if there is a difference, it may be less effective because there would be underlying factors that, higher risk people may not confer such strong immunity.
So what have you learned from your previous rotavirus and pneumococcal studies in terms of the comparison between efficacy, trial data, and real-world evidence? Isn't it true that the fact that there is so little difference for RSV between efficacy and effectiveness data, that is actually quite reassuring that it works as we hoped it would? So what were your experiences, for example, for rotavirus? Can you discuss that, comparing trial data versus effectiveness data?
Yeah, so the common thing is you see that in real world settings, the vaccine may not perform as well because there's a lot of other biases and confounders. And I think that was what happened with the rotavirus. It was some time ago that we did this. I didn't actually study the vaccine effectiveness. We did impact. So we looked at the reduction in cases. But there is evidence to show that the rotavirus vaccine doesn't work as well in different populations because it's an enteric vaccine. And if you have high rates of other enteric infections, bacterial infections, then you don't produce as good immunity. This is also something that you see with the polio vaccine. So in that case, the effectiveness is not as good as the efficacy.
Yeah, exactly. So for rotavirus, I think that is more obvious than for RSV because of the things that you just mentioned. So Mauricio from Argentina asked a very important question. How do we understand the impact of a vaccine on mortality? It's such a rare event that it's so difficult to demonstrate impact on mortality other than pre-post comparison. Do you have any other idea and just guide us as an RSV community how we should get our heads around that a little bit better than just pre-post?
Yeah, I mean, I think it's a challenge for, all studies because it's such a rare event. You need a very large sample size. I think doing the study in settings where there is higher mortality, you are likely to see a bigger impact. I'm not sure of specific methodological anything other than that. I mean, you can look at all-cause mortality, which is more common, and you may see an effect. But I think you need to have a number of studies with a larger sample size in a population that has a higher infant mortality rate, and you would tend to see a better effect.
Do you see any value in a test negative design study on children dying from respiratory disease? With that, and then basically follow the same path, but then with a very different target population. These are very difficult studies. I know that the Argentinians did mortality studies, but some others in the world did so too. So is that something that is feasible?
Yeah, I think so. I think it could be feasible, but it would take time, again, because it's a very rare event. So I think if there's enough data recorded in different places, we may be able to put it together as a meta-analysis. Yeah, I think it's feasible.
Yeah, so the people who did those post-mortem studies showing that RSV contributes to mortality, if they would do it again, but indeed, it's a quite labor-intensive exercise. Let me check whether there are other questions from the audience. Yes, there are. So Fuzi Shebut asks, given the limited surveillance infrastructure in many LMIC, how to ensure the accuracy and reliability of RSV burden estimates, and what approaches to use or have been used to compensate for these gaps? Limited surveillance infrastructure, this is the name of the game, right?
Mm-hmm. Yeah.
What are your thoughts?
So I think really the lessons I learned from the pneumococcal were and the rotavirus is quality surveillance is really key. I think with the pneumococcal evaluation, we use routine data and we pieced together and retrospectively extracted and reclassified the cases. And it was very challenging, and it was hard to really see the vaccine effect in that. So I think, setting up a quality surveillance system is really, really important.
Yeah, I think this is basically the most important message, right? It costs, but it pays off. This surveillance, a limited surveillance infrastructure indeed is an issue, but probably it's one of the most worthwhile efforts to improve, to understand not just RSV but other vaccines. So basically, get a hold on control idea of what's happening in your country. I hope that I'm curious if feel free to respond again, Fuzi. So there is a question about post-marketing or real-world evidence studies in Brazil. Are there any plans? So I don't know, honestly. I have no idea. Maybe Rita, or I know that maybe others in the webinar. If you know, please respond in the Q&A, so then it makes it more interactive. Do you know of any Brazil studies from your colleagues? Rita?
I don't know.
No.
I haven't had a close link yet.
Yeah, so thank you for asking that, because it appears that South America is a continent that can teach us a lot, because you use both the maternal and the monoclonal antibody, and there's both high and lower income settings. So it's really an interesting continent to teach the world. Thank you for asking, but I don't know. Maybe others know. So Maurizio asks, are there lessons learned from PCV studies that we can use as mimicking invasive pneumococcal disease. So I think he means in RSV, in the context of an RSV vaccine, can we learn anything from the PCV studies? Interesting idea, right?
Yeah, I'm not so sure about the mimicking invasive disease. I think the challenge with the pneumococcal studies, and it's very difficult to measure invasive pneumococcal disease in an LMIC context because it's hard to isolate the organism, particularly if for a pneumonia case, it may not be in the blood, or if it is in the bloodstream. If you have invasive disease, it's also very hard to isolate and grow the organism. It's very fragile. But luckily, that's not the case with RSV. RSV, there are good diagnostics, and that makes all the difference. And I think that was the difference. It was more, in some ways, it was more similar to the rotavirus studies that we did because you have the availability of a quality diagnostic.
Yeah, but similar to the post-mortem test negative design approach, I think those people who study invasive pneumococcal disease, they might want to understand how that relates to RSV immunization status. But then what would be the comparison? Because that is often limited. Is there any comparison that you would advocate?
I mean, yeah, I mean, there's, as we know, there's probably an interaction with the RSV and pneumococcal. So I guess you would like to measure both in your study population and see if by reducing RSV, you're also going to have an effect on pneumococcal disease and vice versa.
Yeah. Yeah, so thank you for asking that. So I just read from the Pfizer team. Hi, yes, I saw you were in the meeting. Thank you for confirming that Brazil will participate in post-licensure studies. So I think all of us are very excited to hear that. I assume that you know this because you're somehow involved in this exercise. So thank you. Let me check whether we have seen all the questions. So if there are no further questions, then I think I'm going to thank you, Rita, for being here today and coming in the RSV team worldwide to tell us your experiences and expertise from other fields, vaccine fields that we can use so badly. And thank you all for being here, all the participants in this webinar. I can see the very, very diverse background of all of you. Thank you. Stay safe. See you soon, and look forward to see you in our next webinar. Bye-bye. Bye, Rita. Thanks.
Thank you. Bye-bye.